progress, and then we can get going. Okay, Tchoyoson, thank you. Over to you.
Thank you, Udana. Without further ado, let's dive in to the first question. And these are the pictures I was talking about earlier. Each of these pictures represents a particular image from a pulse sequence, which you should be familiar with if you've had practice hands-on. If you haven't, we will go through some simple methods of identifying whether the correct picture is appearing at the MR console a little bit later. So each of these pictures is a different pulse sequence, and that's the beauty and the magic of MRI. Now, let's go on to question 2. What is the most useful single pulse sequence to detect cerebral infarction? And the choices are T1, T2, diffusion, and post-contrast images. So today's lecture, I hope to go through some of the cerebrovascular diseases that we will come across. But first, I will try to segue into the basics of image interpretation and then drill into CNS diseases. Before that, we will talk about some of the techniques and the grayscale features that radiologists use to make diagnosis. We assume a basic knowledge of brain anatomy and pathology, specifically the anatomy of the brain and its blood supply, and therefore also those pathology that can affect the cerebrovascular system. We'll talk through ischemia, venous thrombosis. We will skip over aneurysms, and then we will talk about vascular malformations. The reason why this will be fairly abbreviated is because many of the diseases that we will deal with in the large category of cerebrovascular diseases is better assessed with CT, especially aneurysms and subarachnoid hemorrhage. Therefore, there will be a heavy focus on MRI and ischemic infarction, as well as chronic imaging in patients with vascular malformations. Cerebrovascular diseases as a group is one of the most important CNS pathologies, and it comprises a very high percentage of our radiology workload. In Singapore, at the Tan Tock Seng Hospital and the SingHealth hospitals, which I work in, there are at least 40 to 50% of our workload comprises cerebrovascular diseases, specifically ischemic stroke and intracranial hemorrhage. Head trauma, ranging from traumatic falls and high-velocity motor vehicle accidents and violence, like assault, comprise the other large group of patients that we see when we scan the brain. Now, my center only does brain and spine, so apart from trauma and cerebrovascular diseases, we also deal with brain tumors, epilepsy, dementia, and CNS infections. But those are more a minority. Cerebrovascular diseases occupies a very large percentage, and in our country, it's the third commonest cause of death after cancer and heart disease. It is a leading cause of disability, even if it doesn't result in death, because brain injury has severe morbidity. And among the non-communicable diseases in Asia and the rest of the world, it is an important pathology. It's made worse as our population changes in Singapore and in East Asia with aging and a sedentary lifestyle and bad diet. The scanners that we have been purchasing for our CT and MR have been increasing in their technology, as well as the new artificial intelligence methods that we will be using. I will talk about practice in healthcare, a bit less for research, except in the area of applied research, where we use pulse sequences for the purposes of daily practice in serving our patients. A mix of our cases comes from emergency and inpatient serious illness from ICU and other places, as well as outpatients, particularly patients who have a known diagnosis and follow-up. So the blend of case mix, I hope, will be applicable to most of the work that you do. The clinical presentation of cerebrovascular diseases is typically in a presentation of stroke, which is an acute neurological deficit. An acute neurological deficit is sometimes presenting as hemiparesis, giddiness, and other reversible deficits. There may be localizing signs, or there may be transient ischemic attacks. Many of the diagnoses, as we shall see, are made on imaging. Many of the patients with cerebrovascular diseases also undergo treatment either by digital subtraction angiogram guided neurovascular interventional radiology treatments or neurosurgery. Either way, imaging plays an important role before invasive DSA is performed. Later on, during rehabilitation and secondary prevention, as well as follow-up, MRI is very often used for surveillance in cerebrovascular diseases, primarily because it does not involve ionizing radiation and is particularly helpful for children. However, since we will not have a large number of ischemic strokes and the number of cerebrovascular diseases in children is much less than adults, my talk today will focus mostly on adult diseases. Later on, we will go into the classification of some of the causes and the risk factors of the different types of cerebrovascular disease. Before we get there, I want to emphasize a little bit about the work that we do as radiologists. To understand image interpretation, we use the technique of MRI to generate the grayscale features that we can observe with our naked eye. With our understanding of the anatomy and what can go wrong with the patient, these observable differences allow us to see the abnormality, so to speak. Most of the things that we do are undergirded by an implied knowledge that we have undergone the suitable exams in anatomy and pathology, allowing us to make the interpretation of the image. How does this apply to cerebrovascular diseases? Here are two patients, patient A and patient B. Both of them have hemiparesis and aphasia. They present to the emergency department with the acute neurological deficit. The patient has a stroke within 3 hours, developing the hemiparesis. How can we distinguish hemorrhagic versus ischemic stroke? It's clinically important because treatment is very different. Patients with cerebral hemorrhage will undergo a very different treatment from ischemia. Hence, with a simple CT or an MR, we should be able to distinguish patient A, who has a hemorrhagic stroke, from patient B, who has an ischemic stroke. Here is the abnormality, which has hyperdensity on the CT density scale, representing blood. And we all know that the clinical reasoning is because blood, which is iron-rich in its acute hematoma stage, stops X-rays a lot more successfully than brain, soft tissue, or CSF. So it appears hyperdense, very similar to the bones of the skull, which also stop X-rays effectively. On the other hand, a patient who has a well-established infarction has cerebral edema and more water per voxel of tissue. Because water stops X-rays less effectively than brain structures, it is hypodense, very similar to CSF, which is almost pure water, and cerebral edema is known to be hypodense. So the grayscale allows us to see, to observe the abnormalities. So the first step is to look for the contrast between radiolucent and radioopaque, or on CT, hypodense and hyperdense. Similarly, on an MR image, here is a patient with a diffusion-weighted MRI of an ischemic infarction. The DWI shows hyperintensity in the abnormality, whereas on the ADC map, there is hypointensity in the exact same area, giving us information that is complementary. So the MRI gives complex physics and allows us to have contrast mechanisms between brain tissue that is normal and abnormal, as well as between different structures that are in the normal anatomy, thereby allowing us to visualize, say, the ventricular structures and, to a certain extent, the difference between gray matter and white matter. So MRI is very much more complicated in its physics. The contrast and the grayscale allows our eye to see the difference. And with our prior knowledge of the physics of image formation, it allows us to understand the meaning of the gray, black, and white. So the contrast mechanisms that we simply deal with are in the region of T1 weighted and T2 weighted pulse sequences. Note that it is not a direct measure of T1 and T2 relaxation unless they undergo specific post-processing of T1 relaxation times and T2 relaxation times, which is a particular aim of the HIBA initiative for quantitative imaging parameters. So primarily, we mostly deal with T1 and T2 weighted and diffusion weighted images rather than the pure physical quantification in the clinics. So I hope that many of you will also be dealing with CTs, because when we decide which modality we use to assess cerebrovascular diseases, there is a trade-off. CTs are advantageous because they are very easily available, inexpensive, and very fast to acquire in the modern multi-detector machines. It's also advantageous because the physics are very simple. The stopping power of the structure to X-rays determines the grayscale, and therefore it's relatively straightforward. However, it's limited in the information compared to MRI, which can probe and interrogate more physical properties than CT. The disadvantage of CT is that there is ionizing radiation, which should be minimized. And of course, patients with iodine contrast allergies will not be able to undergo contrast examinations. The advantages of MRI include that there is no ionizing radiation, therefore they are suitable for pediatric and pregnant women. There is a very high contrast to noise ratio, and the multiple properties of edema, flow, diffusion, perfusion, and angiography can be interrogated using a variety of pulse sequences which are generated by the radiographers and technologists. It's inherently multiplanar. It's much easier to acquire the coronal and sagittal images directly with the MR. However, CT is also very good at multiplanar reconstruction nowadays. The disadvantages of MRI are directly opposite of the advantage of CT, in that it's limited in availability and cost. In our center, we are one of the few places that offer a 24-hour MRI service for our stroke patients. So it is very difficult to train enough radiographers and technologists to provide 24/7 service all through the weekends, 365 days a year. The MR scanning, because it takes multiple pulse sequences, also takes a longer time. And of course, pacemakers are relatively contraindicated unless they have been certified as conditional in MR safety. So these are some of the trade-offs that we deal with in deciding whether to use MR or CT in brain and spine diseases. And in our center, we should be prepared to use either of these modalities and to make the interpretations in case there is an allergy or a relative contraindication that precludes the use of one. We can try the other. So for the radiologists, the diagnostic difficulty, the diagnostic question is similar. We just have to master both the advantages and disadvantages of both systems. Having said that, in terms of systems-based practice within the hospital, CT is efficient, available, and low cost for patients who have trauma or hemorrhagic diseases of the brain, such as hemorrhagic stroke. This covers many examples of cerebrovascular diseases, particularly CT and CT angiogram are the primary workhorse and the first choice for aneurysmal subarachnoid hemorrhage, taking away a very large chunk of cerebrovascular disease. So unenhanced CT is a first-line imaging modality. I showed earlier the hemorrhagic stroke versus the ischemic stroke. Clinically, we can't tell them apart. With a CT, it's very straightforward, it's simple, and it's cheap. In stroke, usually a CT is helpful to rule out those patients that don't have cerebral ischemia. A patient with a sudden neurological deficit could present with a hemorrhagic stroke with an intracranial hemorrhage, or present with subarachnoid hemorrhage, or sometimes stroke mimics such as hypoglycemia, tumor, and others. CT, unfortunately, has a very poor sensitivity to detecting a cerebral infarction. Not every case is going to be well established and sharply visualized like in this. particularly if the stroke burden is small and the patient is seen early. That means stroke CT without contrast enhancement is going to be poorly sensitive to detect the infarction. That's why we tend to use CT angiogram and CT perfusion, and in many of our cases, we will use an MRI in the first 24 hours of the patient's presentation to our hospital. So, remember we talked about the different pulse sequences and what they look like and the reasons why we use them. So let's go over them quite quickly. These are the answers. And we recognize, starting with a T1 weighted MR image. We use this primarily to assess the anatomy of the brain. And for those who are familiar with the appearance on CT, it looks fairly similar to the CT, with the CSF being hypo-intense. Of course, there are slight differences with the CT because the bones are not high in signal. Instead, the subcutaneous tissue is increased in signal intensity. Nevertheless, the one that looks very similar to a CT is usually the T1 weighted, whereas the one that has the CSF being hyper-intense is usually the T2 weighted MR image. FLAIR is an image that is interrogating T2 weighted information. So when there is increased water, such as in cerebral edema, FLAIR will show high signal intensity. However, fluid attenuated inversion recovery FLAIR is slightly more sensitive than T2 weighted MR image, in the sense that it removes the distracting hyperintensity of normal CSF. So we recognize the FLAIR by the fact that the CSF is null and there is low signal intensity, thereby allowing abnormal high signal intensity areas near the ventricles or near the sulci to become better visualized compared to a T2 weighted MR image, where the high signal intensity might obscure the pathology. So FLAIR is T2 without the glare of the CSF. The gradient recall echo or susceptibility weighted image in some pulse sequences is specifically used to detect low signal intensity from deposition of iron or calcium. Because those do not have any mobile protons, therefore, their voxels will have a signal void that has susceptibility effects affecting the voxels that are surrounding it. So in other words, the extent of the low signal intensity is a lot more hypo-intense than the actual voxels themselves. So this susceptibility weighted image using a gradient recall image with a small flip angle is very sensitive to iron in blood or calcium. So T1 and T2 weighted images are relatively insensitive to blood products, but a gradient, GRE or SWI, will help us to overcome that problem and detect small amounts of blood in hemosiderin or subarachnoid hemorrhage. Lastly, a DWI picture can be recognized usually when the image is seen as a very low spatial resolution picture. The reason is that many of these images have a matrix of 512 by 512, or sometimes even 1024 by 1024, whereas diffusion-weighted image is typically presented as a 64 by 64 matrix. So it's much poorer spatial resolution, but has better contrast resolution, which we will see in detail later on. So to recap, the one that looks like a CT is usually a T1 weighted MR image, where we look for the anatomy. The T2 weighted MR image, where the CSF is hyper intense, is very good for pathology comparative to the anatomy that the T1 allows us to see. Flare is the T2 information without the glare of the CSF, because we've nulled the CSF to make it hypo-intense. Gradient, recall echo, and susceptibility weighted imaging is looking for low signal from iron and calcium. And the low resolution picture is usually diffusion weighted, very good for detecting cerebral infarction. A simplified flow chart of a brain image goes like this to distinguish a CT from an MR by looking at the skull versus the T1 weighted, where the skull bones are low in signal compared to the hyperdensity, and then focusing on the CSF. If the CSF is hyperintense, it usually is a T2 weighted MR image or a low resolution ADC map, which is constructed from DWI. If the CSF is black, it's usually either a T1 weighted MR image or a flare or diffusion, which is low resolution. And we have the others, including gradient recall echo and less commonly used now, proton density, where the CSF is gray in color. So that's a very simplified and oversimplified method of telling which image is which. Now I'd like to focus on diffusion-weighted MR imaging. The physics of DWI are that if you put a pair of diffusion encoding strong gradients on either side of the spin echo or gradient echo EPI, this allows us to study the molecular movement of water. So at the molecular level, free diffusion of water will result in low signal intensity on the diffusion-weighted imaging. In a diffusion image, CSF is where the water is free to move in all directions, and therefore the signal fades when the image is captured. In the normal brain structures, there is partial diffusion and there is intermediate signal intensity, as you can see here in the normal gray matter and white matter. In abnormal pathology, the biological result of cerebral infarction is cytotoxic edema. That is when a brain tissue is cut off from high energy ATP. When blood ceases to flow, the sodium-potassium ATP pump fails and water is restricted in its movement inside the dead tissue. As a result, the ADC is decreased and DWI is hyperintense, as shown in this patient with partial MCA territory infarction. So the very early experiments done in the 90s showed that this was a tremendous decrease in ADC all happening within 15 minutes of occlusion of the middle cerebral artery. So the contrast to normal ratio is extremely high, and the noise is negligible in a DWI. So this makes it very attractive for us to use this as a detector for cerebral infarction. So to recap, in a diffusion-weighted image, DWI, high signal intensity in the infarction is usually mirrored by low signal intensity in the ADC. And in our department, we combine the imaging of the brain with an angiographic imaging that will help us to build a coherent picture of what we are dealing with in terms of ischemic stroke. I want to talk a little bit about the MRA and MRV. There are three classes of pulse sequences that we use for acquisition. And they include time of flight, TOF, phase contrast, or PC, or contrast-enhanced MRA and MRV. They have their own advantages and drawbacks, but they all produce the vascular structures. Here we can see the circle of Willis with the internal carotid arteries, middle cerebral arteries, anterior cerebral arteries, the vertebral arteries joining the to form the basilar artery, and then the posterior cerebral artery on both sides. Here you can see the depiction of the posterior communicating artery on the right side. So this happens to be a time of flight, MRA, where inflowing protons into the voxel will give us the flowing blood information. Phase contrast uses a slightly different method of using vascular encoding to code for fast-flowing MRA or slow-flowing MRV and cut off the velocity for the other structures. These two, time of flight and PC, do not use contrast injections and therefore can be successfully acquired in pregnant women and patients with contrast allergy or kidney failure. However, there are some artifacts and some pitfalls, false positives and false negatives in the interpretation of time of flight and phase contrast. To overcome some of those difficulties and ambiguity, sometimes we can resort to contrast-enhanced MRA or MRV. This is where a bolus of gadolinium is injected, and then the vascular tree is reconstructed. So this makes it less prone to the ambiguity of false positives and negatives. That is why in many of our studies with vascular diseases, we usually use time of flight, or in some instances, phase contrast, without necessitating contrast injections. And we may need to recall the patient if we are unsure for contrast-enhanced MRA, or even proceed to a CT angiogram or digital subtraction angiogram. So there are many choices. There are many different types of pulse sequences that are selected according to what the vendor has prepared, and you'll come across them in your practicum, I think. These are just some examples of what MRA can show us in ischemic infarction and stroke diseases. Here's an example where the normal internal carotid and MCA and the abnormal internal carotid artery shows very poor flow into the ICA and MCA. And in response, there is an attempt at collateral vessels formation at the PCA to supply the middle cerebral artery territory. A different patient with unilateral narrowing of the MCA compared to the opposite normal side, there is poor filling and poor flow signal in the narrowed but not occluded MCA. This is a patient with an AV malformation, which shows that the PCA does not decrease and taper and decrease in caliber like most normal blood vessels, but instead has a thick arterial supply into the nidus and early draining vein into the superior sagittal sinus. This represents shunting in an arterial venous malformation, which we will come across later. So these are some examples of the arterial tree that we can acquire. These are all using time-of-flight pulse sequences. So I mentioned earlier that we have a stroke protocol, and we run this 24 hours a day because in our aged population, there is a high requirement and a long waiting time for stroke service. So in order to clear as many patients as possible, this is our pulse sequence chart in the Philips scanner that we typically use. We put in diffusion weighted, we put in MR angiogram, a T2 weighted MR image, and a gradient recall echo. Note that our MRA does not cover all the way to the vertex, so we do not see these vessels, whether they are normal or abnormal. The primary coverage is around the circle of Willis, where most of the aneurysms and most of the occlusions in the patients with ischemic stroke will occur. So we cover only limited anatomy. The purposes of selecting just 3 pulse sequences and MR angio is that the DWI helps us to detect all the recent infarcts. The T2 will detect or rule out other diseases in other parts of the brain, and they are very helpful for detecting tumors and other structural abnormalities that do not result in high signal on DWI from infarction. So stroke mimics, we depend on T2 weighted MR images to assess, as well as other findings such as chronic infarctions, dementia and atrophy, etc. And finally, I mentioned that GRE is very good for hemorrhage, and any hemorrhagic conversion of an ischemic infarct, we depend on the GRE to detect low signal intensity. Of course, I showed you MRA that detects stenosis and occlusion of the large vessels. We also have an ultra-fast stroke protocol for restless patients. And many times this becomes, unfortunately, quite necessary in especially elderly patients who are confused and have supervening dementia as well as ischemic infarction. So the fast T2 and a fast single-shot DWI, the fast gradient recall echo, and ultra-fast MRA can also be selected by the radiographers instead of the standard protocol if the patient is unable to cooperate for a long period of time. The disadvantage is that the T2 weighting in this, which is a half Fourier transformed image, is not as strongly T2 weighted compared to the normal T2 weighted image. So it may be less sensitive to subtle changes and small abnormalities. But it's a trade-off that we can use at least some images. The hardest is the MRA, and very often many of our fast protocol MRAs are uninterpretable beyond the circle of Willis. Let's carry on our focus on ischemic infarction. Once we detect the abnormality, we will try as radiologists to determine the infarct pattern. We will try to classify them into large vessel occlusion, small vessel lacunar infarcts, cardioembolic infarcts, or if we can't classify them as such, then they are classified as unknown. Each of these pathophysiology mechanisms has a different prognosis and risk of recurrence. So the treatment for a cardioembolic cause is going to be different than the treatment for large vessel or small vessel occlusion. And here you can see there are multiple focal areas, some confluent on one side only of the cerebral hemisphere. This patient had embolized, artery-to-artery embolization from the internal carotid artery. So the answer to the previous question, what is the most useful pulse sequence to detect cerebral infarction, is of course DWI. And here you can detect that there's high signal intensity in one cerebral hemisphere and also in the opposite cerebral hemisphere. This means that this patient has a different disease than this one. Here is a patient who has a large vessel occlusion of the anterior cerebral artery on the left side, causing an ischemic high signal intensity on DWI in the area we associate with the territory that's supplied by the ACA. So in large vessel occlusion, we expect to see the vascular territory of the affected artery being positive. So here is our anatomy of the perfusion territory marked in gray for the MCA and in white for the ACA and posterior cerebral artery, also unfortunately in white. So the brain perfusion territory is the anatomy that radiologists use for assessing the extent of infarction. Here's an example of a small vessel lacunar infarct, which on the DWI has high signal intensity, and on the T2, it is less high signal intensity, but it is concordant with the DWI. You'll also notice that this patient doesn't just have this single infarction. There is another infarction located anteriorly, and this has very, very similar signal intensity to the CSF, representing a chronic infarct that has taken place years and years ago. So, although a chronic infarct and an acute infarct are both high signal intense on T2 weighted MR image, on the DW, it's very clear that the acute infarct has high signal and the chronic infarct does not, and in fact has low signal intensity similar to the cerebral fluid. So small vessel disease, and we can tell acute from chronic infarction. Here's a patient I showed you earlier with multifocal tiny infarcts. These are very unlikely to be multifocal lacuna small vessel infarctions occurring simultaneously. And because of the location of infarction on both sides, as well as in the posterior circulation, this patient is likely to have a cardioembolic source. And it was supported by the fact that this was an intravenous drug user, and subsequent investigation on echocardiogram showed valvular vegetation, septic embolization, and cardioembolic infarction very well depicted as multi-territorial and bilateral in nature. The flare image, in comparison, is also able to visualize, but the contrast noise ratio on the DW is superior. Okay, so in Singapore and in many parts of the world, acute stroke treatment has become very much more exciting, active, and it has changed in the past 10 to 15 years compared to previously. That is because intravenous thrombolytic therapy and intra-arterial thrombectomy is now becoming very important. Hence, the mechanical thrombectomy, which allows us to have the interventional radiologist place a catheter right up to the clot and the occluded artery to retrieve or have mechanical thrombectomy processes in order to recanalize the occluded artery and reperfuse the ischemic brain. Because time is brain, as we've been told, and neurons die very quickly, the therapeutic window is highly limited, and we need fast imaging and a 24-hour service for patients who will undergo mechanical thrombectomy. So in our center, we will use CT methodologies, and sometimes we will use MR for assessment, particularly in patients who have wake-up stroke or unknown time of onset. This brings us to the MR method in the acute thrombectomy situation. When there is an unclear time of onset, such as wake-up stroke, in a patient who has an occlusion, these two patients, patient A and patient B, both have abnormal high signal intensity in the diffusion-weighted MR image of the middle cerebral artery territory. The patient which has a matched defect between flare and diffusion will have a poorer prognosis compared to a patient with a better prognosis where there is a mismatch between the two images. Here, even though DW is high and abnormal in signal, in this patient, the flare image is already abnormal and high in signal, whereas this is not, signifying that probably this patient has an earlier, has a shorter duration of infarction and a later onset compared to this patient who probably had his infarction much longer and therefore has poorer prognosis. So this is the flare DW mismatch sign that has been published in the literature. We sometimes use this for prognosis in our cases, in addition to looking for T2, gradient, diffusion, and MRA. So I hope that it wasn't too confusing in our description of cerebral infarction, where DWI is a very strong workhorse. Another class of cerebrovascular disease is venous sinus thrombosis. When cerebral venous thrombosis occurs and the clot, the occlusion, forms not on the arterial side, but on the venous side, this also gives rise to abnormal findings that we radiologists would be very interested to see and to make the diagnosis. Unfortunately, because arterial thrombosis is much more common than venous thrombosis, it is very often missed and misinterpreted initially, and the occlusion isn't always easy for us to detect. Although it's important and fatal, we often miss this, and therefore we need to have a very high index of suspicion. The reason is that unlike ischemic stroke, which gives a very immediate neurological deficit, venous thrombosis is very non-specific and can be of slow onset. The number one symptom is usually headache and non-specific. If the headache gets worse and the thrombosis in the vein is not reversed, the conscious status may be impaired and the patient may have neurological deficit or seizures. We very often see these patients in individuals who are either pregnant, postpartum, or have been taking oral contraceptives, or are dehydrated, or suffering from a prothrombotic state such as malignancy or thyrotoxicosis. There are two groups of MRI signs, and very often we are looking for the direct sign of the venous thrombus in the superior sagittal sinus. And here's an example of a T1 weighted and a T2 weighted image, both of which are normal. And here is an abnormal high signal intensity in the superior sagittal sinus, which is thrombosed. And this is very difficult to perceive because it is in the midline, and if we're not careful, we can miss this patient who has headache. So the direct signs of the thrombosed vein can be hard to see, and if we acquire MR venogram, it is much easier for us to visualize. But of course, we have to have a high index of suspicion in order to order the pulse sequence in the first place. If unchecked, the patient will develop cerebral edema and possibly hemorrhage, usually at the vertex of the head in patients with superior sagittal sinus thrombosis. And here is an example of a normal time of flight MR venogram, where we can see the normal superior sagittal sinus, the normal straight sinus, and the normal transverse sinus on both sides. Here's a patient with thrombosis, with very poorly visualized superior sagittal sinus, thrombosed here and here. The straight sinus is thrombosed and missing, and the transverse sinuses partially thrombosed and missing. So venous thrombosis and normal in a patient with time of flight MR venogram. So to recap, Arterial infarction presents clinically, very strikingly, very typically, and far more often than venous sinus thrombosis, which is very difficult, even in the best hands, to make the diagnosis. Now let's talk about intracranial hemorrhage. Intracranial hemorrhage, the appearances of blood products, hemoglobin breakdown products on MRI is very complicated. The signal intensity on T1 weighted MR images will change in its signal intensity from iso-intense or hypo to hypo to hyper, and then back to hypo in the different phases as time passes. Likewise, the T2 weighted MR image also changes in its signal intensity on a different time scale than a T1 weighted MR image. So for instance, in the late subacute stage, usually older than 7 days, where the blood product is extracellular methemoglobin, this is when the signal intensity is hyper on both T1 and T2 weighted MR image. And in a chronic state, they are hypointense and hypointense on both pulse sequences. In the acute and the hyperacute, sometimes we do not come across the patients are very seldom scanned in this situation. And the combination of the signal intensities allows us to detect the blood products. So this is a lot more complicated, and we will have to use the synthesis of the different pulse sequences when we describe the hemorrhagic blood product in the thalamus in this particular case. And here's T1 weighted, where it's iso signal, T2 weighted, where it's decrease in signal intensity, and on flare and gradient recall echo, they are susceptible with low signal intensity. So it's very much more complex on MRI, but it's a lot easier to detect and to make out on a CT. So here's an example of CT hyperdense intracranial hemorrhage compared to the MR signal intensities. So just looking at these two images, in terms of intracranial hemorrhage in a patient with hemorrhagic stroke, we try to distinguish them between primary intracranial hemorrhage and secondary intracranial hemorrhage. These primary are usually in the deep structures, particularly the basal ganglia and the pons or the thalamus, caused usually by hypertension, and the treatment is to treat the underlying hypertension, or if the patient has had anticoagulant treatment resulting in iatrogenic bleeding, to stop the anticoagulant treatment. Compared to a periphery located hemorrhage in the cerebral hemispheres, these secondary hemorrhages, we need to suspect that they may be caused by secondary abnormalities, including cerebrovascular disease, such as AV malformation or venous sinus thrombosis, or neoplasia, such as glioblastoma, metastasis, and oligodendroglioma. So a patient with a peripheral hemorrhage, we need to suspect AVM or tumor. And the management of these patients is to search for the abnormality using angiographic methods or contrast-enhanced MRI to detect the tumor that is causing the hemorrhage. So here are some examples of secondary hemorrhage. Here's a peripheral hemorrhage and the associated calcific nidus in a patient who has AV malformation. And the DSA shows us very clearly the dilated feeding artery, the nidus, and the beginnings of the draining vein. So this leads us to the class of diseases called vascular malformations. These malformations are local collections of abnormal vessels that are abnormal either in structure or in number. They are non-neoplastic vascular malformations, but they can grow. That means increase in size, even though they are not cancerous and they're not dividing. They are getting bigger and more complex in their flow and their structure. So the altered blood flow usually results in a shunt from the artery to the veins, or they can steal from the normal tissue, causing ischemic disease in some of the surrounding brain or spine. Many of the vascular malformations are shunts and can be divided into two groups of vascular malformations, namely AV malformations, where there is an abnormal nidus of malformed capillary bed from the artery through the nidus to the vein, or in an AV fistula where there is no nidus, where it shunts directly from the artery to the vein. So this is how the pathophysiology is classified. Those with shunting, as I've mentioned, AVM and AVF, including dural AV fistula, CC fistula, and other types. And those vascular malformations that there is no shunting, including cavernoma and developmental venous anomaly. It's not important for us to be completely able to tell these apart, but for the radiologists among you, this is the types of distinguishing marks that we will make. Here's an example of an AV malformation where the nidus in the malformed capillary bed shunts from the artery to the vein, whereas an AV fistula directly shunts from the artery to the vein without nidus. So, to recap, these are developmental vascular malformations with an intervening nidus. These are small, tortuous, thin-walled, low-resistant shunting vessels that can be calcified, and those can be detected on CT or MR. How AV malformations present is, as I've described previously, intracranial hemorrhage, and they have risk rate of about 2 to 4% per year. In patients who are unruptured, they can present with seizures or headache, and we detect them on CT and MR. I'm sorry, I think I may have run a little bit over time, so I'm going to wrap it up very quickly, and we will dispense with some of these, more medical and technical related things. So an example of AV malformation in a patient who did not have a hematoma. And what we look for in these patients is we assess the feeding arteries, the nidus, and the MR draining patterns. We'll skip this. Some of the newer techniques for AV malformation include 3D susceptibility weighted imaging, where the hyperintensity can be detected in the shunt. So somehow my video doesn't seem to be working, so we'll skip that. Whoops. So the importance for AV malformation is in its surveillance. In the MR, non-invasive methodologies are preferred compared to CT angiogram and DSA. So for patients who have an AV malformation that is either partially treated with radiation therapy or untreated, follow-ups can be arranged in the first few years with invasive DSA reserved for the later years. So using the CT and MR techniques, we can try to use non-invasive methodologies. So to recap, the imaging techniques include CT and CTA in the first study. In the follow-ups, time of flight and dynamic time-resolved MRA, and finally, perfusion MRI and susceptibility-weighted MR image. So to conclude, I've gone through a little bit about the techniques and the grayscale observable features that we use as radiologists to visualize the different contrast mechanisms in T1, T2, FLAIR, and DWI, plus the neuroanatomy of the vascular knowledge of the arteries and veins. With MR, cerebral infarction is very important as a 24/7 service in my hospital, whereas venous thrombosis is less common and needs a high index of suspicion. Vascular malformations, particularly AV malformations, require a lot of surveillance MRI. So that's it for my presentation. I apologize, I did not realize that
that's okay, Tchoyoson. They're all still here. It's we're still going. It's 40 participants still on board. So we can actually take questions.